Hi, everyone. My name is John Faulkner. I'm your host of the Smarter Systems Better Care podcast. I'm here today with Dr. Jay Harness, where he is from the Maple Tree Cancer Alliance and a leading voice in integrative cancer care and survivor support. Welcome to the podcast today.
Hey, John, it's a real treat to be with you. Thank you very much.
You're very welcome. And just to give our listeners context, tell us a bit about your background.
Sure. I'm a University of Michigan educated. That's where I did med school. Then I stayed at the University of Michigan to do my surgery training. Then I ended up staying on the faculty in Michigan for 14 years. And my focus has primarily been in surgical oncology, particularly for breast cancer patients. Was recruited out of the University of Michigan in the late 80s, briefly in Boston for a couple of years, then spent the remainder of my career in California, part of the UC California system, and then subsequently in a private hospital down in Orange County, California. And more recently, after I stopped operating a few years ago, got involved in this world of not only integrative oncology, John, but particularly the world of exercise oncology, which most people have never heard of.
No, I have not either. Do you want to tell us more about that?
Yeah, I would love to. So the term makes sense. Exercise is exercise. Oncology is cancer. And really, unbeknownst to me, starting in the early 90s, were early research studies done on the importance of exercising cancer patients, starting right at the time of their diagnosis, during their active treatment, and particularly into long-term survivorship. And so what emerged out of that is a discipline called exercise oncology. Since the early 1990s, there have been a little over 3,000 clinical trials done, generating over 30,000 publications. Most of those publications, however, have been in the PhD literature. The researchers were PhDs in exercise physiology, kinesiology, even sports medicine, with very little of their publications filtering over not only into general medicine, but particularly into my world of cancer care. And so what I've been attempting to do over these past few years is to have an advocacy role as a physician spokesperson for this discipline of exercise oncology.
That's amazing. You're truly working on something special here. And most of your focus is on Maple Tree Cancer Alliance. Is that correct?
Yeah, Maple Tree is a not-for-profit founded a little over 15 years ago by Dr. Karen Wonders down in Dayton, Ohio. Karen is a PhD researcher, of course, in exercise physiology. And one of the reasons she started Maple Tree was because her own grandfather had colon cancer. And of course, during his treatment, the doctor simply said, "Would just go home and rest." And Karen knew from her training and background, and she had started to focus during her PhD on cancer patients, that it was really important for her grandfather to get moving. And she worked with him and got him moving. He unfortunately passed away eventually from his colon cancer, but in that process did ever so much better than maybe other people would. And so she started Maple Tree. Maple Tree is, as a not-for-profit, provides certified exercise oncology specialists to a little over 80 locations in the United States, 5 in Brazil, and in, I think, 22 countries internationally. Karen has exported educational programs to help local people set up their own exercise oncology program. And so I live in Arizona, and I work virtually and part-time, but try and give her lots of advice and to be her physician advocate for this wonderful and exciting world of exercise oncology.
Yeah, that's amazing. Can you mind give us kind of like a feel for these programs? Like, what is an exercise program for this look?
Sure. A lot of the research has been done in breast cancer patients. In fact, a little over 60% of that research. So here's a good example. Newly diagnosed breast cancer patient is hopefully in a center that may then refer her onto an exercise specialist to be evaluated, to set a baseline. It ends up, well, let me ask you this question, John. What percentage of the American population do you think actually exercise regularly?
Maybe 25%. It's got to be a low
Hey,
number.
that's really close. The reported number is actually around 22% or so. So
Yeah, it's pretty close.
yeah, you are very, very close. But it ends up, Maple Tree has a cloud-based data collection system. And of the over 15,000 patients in that system, it's barely around 14% of newly diagnosed cancer patients have actually been exercising at all regularly.
Yeah.
Whether that could be playing golf regularly or pickleball or tennis or bicycling or whatever, only around 14%. So anyway, you want to do an initial assessment. What's the status of the patient? Obviously, their age, their vital signs, things of that sort. What's been their level of exercise prior to their diagnosis of cancer? And then we always have to have permission from their physicians to work with a patient. And that's not difficult to do because the side effects, if you will, of exercise might be sprained ankles or things of that sort. And then try and create a plan based on the baseline characteristics of the patient, the cancer that they're being treated for, and where they are in their treatment. So the
Mm.
plan may be a little bit different if they're just heading into chemotherapy, or even before they start their treatment, we want to get them moving to help them do better during treatment, or it may be modified some while they're in radiation therapy, etc. Okay? So it's an individualized prescription of exercise for each patient.
That's amazing. Sounds like there's definitely data there to support that. There's clearly a need in this area to get people moving, especially after diagnosis. Because I heard you say 14%, so it's pretty low for the numbers.
Yeah, Dr. Wonders tells the anecdotal story of more than one occasion of patients saying they were more afraid of starting their exercise program than they were getting their chemotherapy.
Wow. Yeah.
So I mean, people, and especially if they haven't exercised, John, are scared. Oh my goodness. Or they may be overweight, or there may be other factors going on. They may have some level of disability prior to their diagnosis. So every patient has to have an individualized program recommended for them and then monitored in these structured programs. It ends up, this is another really important point. If a medical oncologist simply hands to a patient a brochure and says, look, Mrs. Smith, here's what you should be doing diet wise, exercise wise, etc. What do you think the odds are the patient's going to follow what I call brochure therapy?
Yeah. Less than 14%. It's going to be
Yeah.
very low.
Yeah, almost next to nothing. However, if they're referred to a structured program, then their odds of sticking to that program are in the 90 some percent range.
Wow. That's amazing.
And it's really important for our audience here today to understand that it's not only at the time of diagnosis during active treatment, but particularly out into long-term survivorship. Because with most invasive cancers, there is a small percentage, or even a little bit higher than small percentage of those cancers that can come back. And in my world of breast cancer, they can come back 5, 10, even 15 or more years later. So it's really important to continue that level of exercise well into survivorship. Now, another important point for our audience today is we've got 35 years of clinical outcome data that shows how much better people are going to do. The real question is what's going on at the cellular molecular level in the body that gives these better outcomes? And that's where the major shift and focus is going on right now, is to start studying that. And it ends up that every time we exercise, our muscles release what are called myokines that circulate around the body, improving the central nervous system, improving our heart, lungs, liver, all of our organ systems. And some of these myokines can actually help to suppress the growth of cancer cells.
Interesting.
The
Yeah.
other thing that's going on is the immune system itself. Every time we exercise, kicks out really important immunological products like lymphocytes, killer lymphocytes, and others that can help suppress or go after cancer cells. And if the future of cancer treatment is going to be immune therapies, where we're creating targeted immune therapies to specific cancers, if we can at the same time enhance the immune system, theoretically the immune therapy ought to do even better. So that's a major focus as we head down the road in this world of exercise and cancer patients. Okay.
Yeah, it sounds like it's an important missing link in the process. It seems like a novel idea, but it's definitely a key part of like the process and may not even be considered in cancer survivorship and helping people have better outcomes as
Yeah.
well.
Yeah, the other big factors here are improved quality of life,
Hmm.
less depression, less anxiety. We actually, in some of our settings, we try and encourage the partner of the patient to go with them to do the exercise, the husband or wife or other partners, because we know that people exercise more regularly if they're in a partnership than they may necessarily on their own, even if it
Right.
is with a structured program. Okay.
Yeah, and like what's looking like big picture too, like the shift in this industry of cancer survivorship, it's always a hot topic on the media and everywhere else. What's something maybe specific to breast cancer that most leaders are not paying enough attention to? You already called out exercise. Is there anything else specific that you've noticed in your career?
Yeah, well, when I went through my training, every woman, no matter what kind of breast cancer, got a mastectomy.
Mm,
That's how I was trained.
yeah,
In the mid 1980s, that all changed when we had a huge national trial from the US and one from Europe that showed we could do what's called breast conservation, meaning we could save the breast, just take the cancer out, check the lymph nodes, follow that up with radiation therapy, maybe chemotherapy if we needed it, or anti-hormonal therapy. And then we've moved ahead in doing needle biopsies of everybody. Back when I was trained, you had to go to the operating room to take the tissue out to know what's going on. Now we have X-ray or ultrasound guided core biopsies to get the tissue. In fact, in the future, I would predict that the core biopsies tissue will be used to create specific immunotherapies based on the DNA and RNA and other patterns of the genes in those core biopsies that we do. That's where we're going to be going in the future. We're doing in my world of breast cancer more by doing less in one sense, and it's far more targeted and it really truly is personalized. Are there breakthroughs in chemotherapy coming? Sure, there are. Are there going to be other breakthroughs? Yes, there are. And then if a patient does need a mastectomy, I was one of the folks that helped to pioneer, in the US at least, what's called nipple sparing mastectomies, where we remove all the breast tissue underneath the skin and nipple areolar area, yet we preserve the skin and nipple areolar area. So when we reconstruct the patient, they almost look like they haven't had any surgery done at all. And
that's
so,
amazing.
yeah, there's much more of a what we call oncoplastic approach, meaning a plastic surgery approach to the kind of surgery that we do now. Okay. So it's very exciting. And
Yeah.
particularly it's going to be very exciting in the immunotherapy arena.
Absolutely. Specific to like your day-to-day operations through the Maple Tree Cancer Alliance, are there, do things ever feel clunky as you're kind of trying to work with patients or, organizations, or is anything moving slower than you'd like?
Well, again, because we have a barrier of reimbursement. In other words, everyone asks me, why hasn't this been more widely accepted? And there are two reasons. One I've already alluded to, which is the lack of education. We've had all these 30,000 publications, yet most of them have been in the PhD literature. So then most of my colleagues are unaware of the science, but that's all changing. And then the issue of reimbursement is a barrier. And we're working on that at the Center for Medicare Medicaid Services called CMS in Washington, and hopefully we'll overcome that barrier. You know, during the COVID pandemic, everything had to shut down because prior to the pandemic, the programs that Maple Tree was running were in-person programs, either individually in person or in groups. That all had to be shut down during the pandemic. And so the real question was, could we also make this work virtually, given that the average cancer patient is probably in his or her late 50s or early 60s? Could we actually do this virtually with an instructor on one end and a patient like you and I are doing on the other end on either their phone or their computer or whatever? And the answer to that question is yes, they can. And that was proven during the pandemic. And in many of the locations that Maple Tree now provides certified specialists, the program is entirely or partially virtual. And so the instructor can be in Ohio and the recipient of the one-on-one or group can be in New York City as a good example. All right. So that's a real breakthrough. And I think you're going to see more and more in the way of digital provision of this kind of care, particularly as we reach out to more rural areas around the United States and even international.
Yeah, you're getting the massive reach, it sounds like. As you're educating more people, they're more aware of the data and the information and the research. They're then, um, sounds like reaching out and engaging with you.
Yeah. And one of the reasons that I loved meeting you a few weeks ago, and you said you were going to do a podcast, what I'm trying to do is to continue to be that spokesperson I was telling you about. But hopefully, as you circulate your podcast, we're going to enlighten some folks. And then importantly, I've shared with you that I have a website called cancerfitness.org. At cancerfitness.org, we've got a lot of the information about the science that's led to the development of the discipline of exercise oncology. And then what we do almost on a daily basis, we post written blogs about the latest information we can find, the latest publications we can find on the importance of exercise in cancer. And then we do that by both written blog and also by videos. A really good example of that is just recently at the American Society of Clinical Oncology meeting in Chicago in June. It was a trial called the Challenge Trial from Australia and Canada primarily, where these were stage 2 and 3 colon cancer patients. Control group was, again, the brochure sort of group, but the study group was 3 years worth of structured exercise programming. And these were patients who had had their surgery. Many of them had chemotherapy, and now they were heading into long-term survivorship. And the results of the challenge trial got a standing ovation at that ASCO meeting in Chicago because it demonstrated a 38% improved survival in those
Wow.
patients who were exercising regularly, particularly in the structured programs, and a 28% lower incidence of recurrence of the cancers. So there's a huge amount of momentum going on in the United States and internationally right now to make this more of a standard of what we call adjunctive care, meaning in addition to surgery, radiation therapy, et cetera, have it be a standard of that care. You're going to see that happen over the next, I think, 2 to 3 or 4 years.
Yeah, that's an amazing statistic. You said 38%
Yeah,
increase. Yep.
improved survival. And remember, in these kind of clinical trials, people are randomized into the group that's a study group or the control group so that you theoretically get rid of any bias that the people running the trials may have. And for that presentation to have gotten a standing ovation before 12,000 medical oncologists in Chicago in June really spoke volumes about how important the research is. Okay.
Yeah, that's astounding.
Yeah.
And now definitely we'll see that in this space particularly be adopted more widely because of that presentation. I'm sure that'll be like the pillar how everything kind of started with exercise and
Yep.
cancer survivorship.
Yep. Yeah. The American Society of Clinical Oncology does have a guideline right now that says that patients who are in active treatment should be referred for exercise in order to help deal with the side effects of their treatments. And then we have another group called NCCN, National Comprehensive Cancer Network, which has a similar recommendation for survivorship. And that's 150 minutes a week of moderate intensity exercise. And everybody goes, whoa, wait a minute, 100. Well, guess what? 150 minutes a week, John, is walking briskly for 5 days a week for 30 minutes. Okay, there's your 150 minutes. And then you combine that with some resistance training in a gym or resistance bands or whatever it may be for the other 2 to 3 days. That's the national recommendation in the long-term survivorship. And we have groups around the country, and for instance, Live Strong at the YMCA's in the United States, where there are organized programs for long-term cancer survivors. Maple Tree Cancer Alliance that I'm with has videos that can be downloaded, or patients can subscribe with a trainer out in long-term survivorship as well. We're hoping that more and more medical centers will get into this, and we're really hoping that the fitness industry in the United States and globally will realize the importance of this kind of management of chronic diseases like diabetes, hypertension, arthritis, and cancer as part of the packages they offer people out in our fitness centers nationally and internationally. Okay.
Yeah, that's an amazing idea too, as well as partnering with even these gyms or these folks in other industries in the exercise industry specifically using this data. This it's very convincing when you frame it like that and tell the story. So I can imagine that would be resonating well with that group.
Yep. Well, we just got to get them to do it. And if you're familiar with the work of Simon Sinek, start with why. What Simon talks about, once you get the why, then you build a circle of what are called early adopters. And what we're trying to do is to grow that circle, and then eventually everybody will get it. Okay.
Yeah, absolutely. And when you're looking at the Maple Tree Cancer Alliance, where do you want to be in 6 to 12 months? Like, what's your vision?
Yeah, we want to continue growing the number of sites that we have specialists at. Excuse me, more and more medical centers are gaining interest in this. Again, if we can get reimbursement, that will open the floodgates to getting more and more medical centers involved.
Yeah, that would be amazing.
It's a process, and what I've told everybody is that unfortunately this is a evolutionary process, not a revolutionary process. And I have to really take my hat off to the people like Karen Wonders from Maple Tree, Dr. Catherine Schmitz from the University of Pittsburgh Medical Center, Dr. Lee Jones from Memorial. These are these PhD researchers that have been at this 20, 30 years or more, finding it out, creating all the data that really substantiates what we're doing here and to stick with it. But I really see the light at the end of the tunnel. And just being with you on this podcast today is a good example of that. Okay.
Yeah, we're happy to have you. And we're at the end of our podcast now, but how can people find you? You mentioned a few resources before. Do you mind kind of restating that one more time? And if there's anywhere else people can connect with you?
Yeah, absolutely. What I would recommend is that they come to cancerfitness.org. We're not a .com, .org, or they can simply email me directly. My last name is Harness, like you put on a horse. My first name is Jay. And so my email address is the letter J, the letter K, then HARNESS at gmail.com.
Thank you for your time today and for this great conversation. I'm excited to share this with my network. And
Well, it's really my privilege, and thank you so very much for the invitation.
absolutely.